Charles Clinton with the Heart of Medicine, and today is video number 20. So I'm almost about to lose track with these daily ABIM preparation videos. So I believe this is video number 20. And as I prepare for the internal medicine certification examination, I'm just sharing with you my main pearls of what I learned failing forward, right? There's no fail. You just try again till you make it. So yeah, failing forward probably makes sense as well. So let's go to the clinical pearls. I'm not just going to read the educational objective. I already reviewed these questions after I got the results. And that's to appreciate your time if you're watching this video. And yeah, hope you like it. Leave me comments, feedback, opinions. But let's get into the action. So this first question is a patient that basically is having abdominal pain. And you see here, abdomen is diffusely tender and tensely distended. So that's interesting. How often do you read these questions saying that the abdomen is tensely distended? It's not that often, right? When they're telling you that this patient needs a surgery or there's acute abdomen, they're usually talking about rebound. They're usually talking about exquisite tenderness. They're usually saying rigid, right? But tensely distended. That's interesting because that's sort of like an emergency, but something maybe a little different is happening here. So when you join that to other findings here, you can see that this patient has alcoholic pancreatitis, so you know that there is inflammation going on in the abdomen. He is intubated, and urine output has decreased, and serum creatinine has increased from 1.2 on admission to now 2.2. And patient has 3+ pitting edema to mid-thighs bilaterally. I think that this is enough information for you to have a clinical suspicion of what's going on. And yes, this diagnosis is going to be abdominal compartment syndrome. So it just means that any compartment of the body can have elevated pressures. So of course, each of our compartments in our body has a normal pressure. When you exceed that pressure, you can have a compartment syndrome. That can happen any place in the body. You can have sort of a compartment syndrome in the eye, right? You can have increased pressure there, generating problems. You can have compartment syndrome after a burn, a circumferential burn on the thorax. Can have compartment syndrome with a severe infection on your leg. In this case, you can have compartment syndrome because the pancreatitis is so bad, it is just pressing on, right? The inflammation pressing on towards the other structures. And that's why this patient has the acute kidney injury, because it's generating ischemia, and these kidneys are affected, and that's why the patient is not urinating. So what you have to check is the intra-abdominal pressure. So how do you check that? You measure the bladder pressure. Very easy. You put in a Foley catheter, and that Foley catheter will be connected to a transducer, and that can give you the intra-abdominal pressure. I recall that when I was in Costa Rica, it was interesting because someone was checking the intra-abdominal pressure, and on that occasion, I think they checked it differently. It wasn't a Foley catheter, or maybe they put a Foley in and they just put in the tube like upwards, and they saw the column of fluid of like urine going up, and they measured that, and that sort of said what was the basically centimeters of water pressure in the abdomen. Probably that was a little bit more of a not so technical way or technological way of doing it. Maybe we had no transducer over there. I don't remember, but that story just tells you the importance of just figuring out how the intra-abdominal pressure is. If you don't think about it, you won't know what's going on. So some risk factors for abdominal compartment syndrome are in high-risk patients, such as trauma and burn patients, liver transplant patients, abdominal disease, such as massive ascites, bowel distension, extensive fluid resuscitation, such as sepsis or acute pancreatitis. So there can be an iatrogenic component to that. Post-surgery with large volume resuscitation, and there are some clinical features. So how do you suspect it? Well, patients usually too ill to communicate, tensely distended and tender abdomen, progressive oliguria and renal injury. Of course, some vital sign abnormalities such as low blood pressure, high heart rate, high JVP, peripheral edema, and hypoxia due to increased ventilatory requirements. So here they use the acronym abdominal compartment syndrome, ACS. Of course, that can be misleading with acute coronary syndrome, but yeah, that's just to make it easier while you read through the question, right? And abdominal compartment syndrome has a high mortality, 40 to 100%. So you have to do something about it. How do you lower that hydrostatic pressure? It could be through surgical decompression. So you have to act quick. And I just summarized a couple more things here, just to refresh some things. Remember that fractional excretion of sodium, if you have a pre-renal pattern, it's usually going to have a FeNA of less than 1%. But if you have intrinsic kidney disease or renal tubular acidosis, you're going to be wasting more sodium. So the FeNA percentage is more than 2%. And yeah, that's about it for this question. Now that we're going on with the next one. This other question is interesting because it's a 45-year-old woman who is found to have findings consistent with meningitis. So the patient has temperature 38.9. She began having a fever, headache, nausea, and vomiting. And the patient was started on broad-spectrum antibiotics, but before, not broad-spectrum, sorry. The patient got, well, first blood cultures were obtained. Antibiotics were started empirically, suspecting meningitis. CT of the head showed no hemorrhage or mass. Well, they did the lumbar puncture right after that. After doing the CT, not all patients will require a CT of the head, only those that you have risk factors for intracranial hypertension, right? And the CSF findings show a low glucose, so hypoglucorrhea, hyperproteinorachia or high protein, and also 1,000 leukocytes with a neutrophilic predominance. And the most important thing here is that the CSF gram stain is showing numerous gram-positive bacilli. So then they are asking which of the following is the best treatment. So they were asking you, okay, these are all the findings. Now, which antibiotic are you going to give? And the clinical pearl here is mainly that you comprehend that you start with your empiric meningitis coverage, And if you get a gram stain, and this gram stain it comes back positive from the cerebrospinal fluid, the sensitivity isn't that high, so it's about 60 to 70%, but the specificity can be up to 80 something percent, so pretty high, meaning that you can tailor your antibiotics accordingly, and of course you can now focus on what you're suspecting. Remember that when you have gram-positive bacilli in general, there aren't so many causes for it, as opposed to gram-negative bacilli. So gram-positive bacilli in a patient with meningitis, you're going to suspect Listeria monocytogenes, and the main treatment for that will be ampicillin. So what I want you to see here is that I got it incorrect with most of the people, and we thought that we still had to maintain vancomycin coverage and just add the vancomycin. Well, we were wrong, because that's what I'm trying to get to when I say that you have all these data points and you have the possibility of this. Oh, now it seems that it's gram-positive bacilli. So that's where you had to down titrate the antibiotics to focus on Listeria. What do you want? You want only ampicillin. Despite many of you thinking, wow, that's risky, right? Well, that's why this clinical pearl over here, focus on what you have at hand. And if that's positive in the CSF, no need to give vancomycin. So yes, ampicillin is the one to give for Listeria. Of course, before having any of this information, you have to go broadly. You have to do the vancomycin. You have to give the third generation cephalosporin, and probably also add on top of that ampicillin coverage if it's a patient with risk factors for it, which we'll see in a second. So let's see, we already spoke about this. No, the specificity in CSF gram stain is way higher than what I said. It's about 97%. And of course, when the lumbar puncture is performed prior to antibiotic therapy, because that way you don't have any false negatives. Of course, if you give antibiotics and many hours later you're checking the CSF fluid, you could have already partially treated whatever that patient had, and that's going to reduce your sensitivity, and well, your specificity probably would maintain. It's pretty similar. Let's see what else we have here. So yes, when to suspect Listeria? Well, you suspect it in neonates, in of course neonates with meningitis, or adults above the age of 50, or immunocompromised for whichever reason, such as this patient, which was immunocompromised. Let's see what was the reason this one was immunocompromised, because she was 45, but she is on maintenance immunosuppressive therapy for simultaneous pancreas and kidney transplant 2 years ago. So there you have it. That's it. That's the main pearl to answer this question correctly. Now I want us to focus real quick on a couple of the other answer choices. So cefepime. You usually don't do cefepime unless you think that the patient has Pseudomonas, right? So patients that are at risk for resistant organisms such as Pseudomonas or Acinetobacter due to immunocompromise, a neurosurgical device or recent neurosurgery or head trauma, that's where you would probably add cefepime, okay? When would you? Well, you always add vancomycin in the initial empiric therapy for meningitis, because you want to cover cephalosporin resistant strains of strep pneumo, which are always something to consider, or when staph aureus or coagulase negative staph is likely, such as a recent head trauma neurosurgery or neurosurgical device. And that's it for this question. Let's go on to the next one. So this other question right here is a 53-year-old woman who had a Roux-en-Y procedure, a Roux-en-Y gastric bypass surgery 3 years ago. This was done because the patient has a history, I think, of Crohn's disease. And let's see if that is correct. No, this is another patient. So this patient just got a Roux-en-Y, okay? And the patient, this was 3 years ago, and the patient is now having some symptoms, some interesting findings, mainly neurological findings. So the patient is having, let's see what the patient is having. Decreased sensation to light touch in her feet and lower legs. She also has loss of vibration and proprioception in feet bilaterally. Strength, tone, and bulk are within normal limits. Gait is narrow-based and steady. Remainder of the examination within normal limits. So that's part of the physical findings, but the patient also has a couple more things, which you can see right here. She has become irritable and may have had some memory loss recently. So when I read this question, I wasn't able to pinpoint exactly what was going on, because when we think about most of the time, when we are studying for these exams and we think about vitamin B12 deficiency, you think about it and you're like, okay, vitamin B12 deficiency, if it's ongoing for a long time, it's going to be associated with subacute combined degeneration of the spinal cord, which usually are the dorsal columns of the spinal cord. And of course, that is associated with proprioception and vibration sense, which are findings we have here. So we have those findings here real clear. But the interesting part here was that the patient also had like some altered mentation, such as being a little more irritable and some memory loss recently. So that didn't add up 100% for vitamin B12 for me. And that's why I was on the fence. I was asking myself, does vitamin B12 explain this on its own, or would I have to think about something else? That's why I also had zinc deficiency as an option, because I wasn't sure. I was thinking about zinc deficiency. Maybe it's associated, maybe not. Well, the answer is no, and we'll get to that in a moment. Yes, the right answer was vitamin B12. And now the clinical pearl. So clinical pearl is B12 does affect the dorsal columns of the spine. It also affects your cognition potentially. So those are the findings of irritability here and some memory loss. And how can we also make the association with the vitamin deficiency and the Roux-en-Y bypass surgery? Well, it's simple, because it is oftentimes associated with patients that are bypassing the stomach. And the reason for that is because intrinsic factor is made by the parietal cells of the stomach. So in a Roux-en-Y procedure, you're bypassing the intrinsic factor. And remember that vitamin B12 joins intrinsic factor in the stomach and then goes down to the ileum to get absorbed. So intrinsic factor basically works like a taxi cab that will hold on to the vitamin B12, take it to the ileum and get absorbed. So now when you're bypassing all that, you are at risk to become vitamin B12 deficient. That is why you have to take vitamin B12 supplementation after RU and Y. And that is why you also have to check vitamin B12's levels, I believe 3 months, 6 months, 9 months, and then yearly afterwards. But let's look at that in the table. So there are several micronutrient deficiencies associated with gastric bypass surgery. We already talked about vitamin B12, and of course we were only missing to talk about the macrocytic anemia, which B12 is associated, yes, macrocytic. And for you to always have that interesting clue how to differentiate macrocytic anemia between B12 deficiency and folate is that in B12 deficiency, methylmalonic acid levels will be elevated, MMA will be elevated, while in folic acid or folate deficiency, MMA is going to be probably normal or not elevated, okay? What other micronutrient deficiencies will you have with gastric bypass? So fat soluble vitamins, that's also going to be deficient because probably you're not being able to get part of those. Yeah, you're probably bypassing those bile salts that usually, or the bile salts will not go as effectively through the GI tract. And of course, the fat soluble vitamins will be A, D, E, and K. Vitamin A is mainly associated with vision, night vision. And I didn't recall that vitamin A was associated with bone growth. So poor bone growth, skin rashes, immune deficiencies. And yeah, so then we have, well, vitamin D deficiency, vitamin K deficiency, some trace minerals such as iron, generating, of course, anemia. Zinc. So zinc deficiency will generate alopecia, night blindness, sorry, and skin rashes to consider. And copper deficiency will generate fragile hair, skin depigmentation, muscle weaknesses, ataxia, neuropathy, and osteoporosis. So yeah, so actually copper deficiency would look a little bit more like a peripheral neuropathy than zinc. Zinc is more, yeah, the alopecia, night blindness, skin rash. Copper is the one that has more muscle weakness, ataxia, neuropathy. You can also have deficiency of calcium, folate, and thiamine in gastric bypass. So we have already hammered the main points here, and now we're ready to go on to the next question. This next question here is a 28-year-old woman, and they're basically asking us what is her diagnosis, and they're giving us several clues. So whenever you read in a question that there is mildly swollen parotid glands, that's almost like a giveaway, telling you that there's probably going to be bulimia nervosa there. Maybe anorexia nervosa, right? Depending on how the BMI is. Remember that for you to distinguish anorexia from bulimia, it's just the BMI. The BMI below 18.5 is anorexia, above 18.5 is going to be bulimia. And the mildly swollen parotid glands is telling you that this patient is chronically vomiting, right? Chronically, probably inducing their own vomit. And some other giveaways for bulimia are that these patients usually have associated psych disorders such as depression or anxiety. So here you can see constipation is another thing that usually can go on. So this patient mentions she has been having difficulty losing weight despite trying numerous low-calorie diets. She is depressed about her weight and feels her appearance has always been a source of insecurity. She is unhappy, those sort of things, right? A patient has an active social life, but is not in a relationship. Okay. So a blood count was normal, but look at this, electrolytes showed some derangement. So not only will you have psychological and weight loss or weight abnormalities, in these situations, you can also have lab abnormalities. So electrolyte derangements is a big one. Mildly decreased potassium, slightly elevated bicarbonate, and mildly decreased serum chloride levels. And the rest of the labs seem unremarkable. Okay, so main point here is, of course, bulimia, which we already mentioned. And yeah, I think we hammered the main points here. Let's see what else we maybe didn't talk about. Maybe the chronic purging can also lead to mild electrolyte abnormalities, including hypokalemia, slightly elevated serum bicarbonate, and slightly decreased serum chloride. Hypokalemia in an otherwise healthy young adult is highly specific for covert bulimia nervosa. And there are other signs suspicious for bulimia, which are oropharyngeal ulcers, erosion of dental enamel, scars and calluses on the back of the hand because they're inducing the vomiting so much that they, I guess, get scars. Maybe, I don't know, somehow maybe hitting their teeth or something. But yeah, I always see that maybe. Yeah. Well, okay, so that's the answer for that one. And I was on the fence between that one and surreptitious laxative ingestion because if you use laxatives like hidden or surreptitious, it can generate these electrolyte abnormalities, but it would not explain the other findings in this patient. So it was more bulimia than anything else. It says surreptitious laxative ingestion may cause hypokalemia, but bulimia with self-induced vomiting is more likely explanation of this patient's parotid hypertrophy. Moving on to the next question. This other one just wants to make you remember that anyone that is taking care of someone who is end of life or has advanced dementia and yeah, sort of thing, can have caregiver burnout. So what they're asking you is, what's the most appropriate intervention for this patient? This patient you are seeing is the family member, is the daughter for basically someone who has advanced dementia, and her mother is waking up at the night and wandering because of her dementia status, wandering at night at home, and the patient isn't able to sleep well, and the patient is finding it difficult to basically go through her daily living. So the main thing here is to recommend respite care and support groups. So when I read this question, I didn't know what respite care was, and I probably am not able to explain it that well to you right now. We will see it right here. But whatever, the support group that sounded good. I recommend respite care. Just out of the context, I assume that respite care probably sounded like the patient taking care of herself, because that's the only way you can cut the vicious cycle of caregiver burnout, right? You have to do something, because just telling the patient, congratulating them on what they're doing, isn't gonna fix the problem, right? Isn't gonna make them better at what they're doing. Yes, I think anyone taking care of their family member, yeah, you have to recognize that's a good human being right there. But you have to try to help them out, so they can be better, so their health can improve. So it's not just patting them in the back and telling them, hey, you're doing what you're doing, that's great, keep on doing it. No, because you have to try to help them improve. So signs of caregiver distress include sleep disturbance, depression, irritability, and anxiety, as well as negative effects on physical health. Without intervention, the situation can progress to caregiver burnout, mental and physical illness, and the increased likelihood of early nursing home placement for those with dementia. Okay, so so that's not a good idea, right? You want to help this patient. Respite care, so early recognition of caregiver burnout and providing assistance with obtaining support services can reduce stress and prevent burnout. Respite care services include in-home care services, adult day centers, and overnight care, which allow caregivers to take a break or vacation. That's so important. Other helpful interventions include caregiver support groups, as well as comprehensive support programs that can assist caregivers in assessing the needs of the patient with dementia and appropriate level of care as the disease progresses. And that's it for that one. Now moving on to the next question. This is a 20-year-old male who has asthma. Asthma had been pretty well controlled, but all of a sudden the patient had some symptoms such as an upper respiratory tract infection, which seems that it's probably viral, and now the patient is having a worsened asthmatic attack. I got this question incorrect because of this. So it says these symptoms started 5 days ago when he felt lousy and had muscle aches, cough, nasal congestion. Thick, yellowish nasal discharge, sore throat, and fever. The fever and sore throat improved, but the cough and nasal congestion have persisted. The patient has no headache. He can barely sleep due to frequent coughing. So I just thought about that, and I'm like, okay, so this is sort of a prolonged symptoms or residual symptoms due to upper respiratory tract viral infection. What can I give this patient for the cough and the nasal congestion? So then I was like, okay, yeah, nasal steroids sound like a good idea, but I didn't think about what was happening in the lower respiratory tract and look at the physical examination. It shows a healthy appearing man who is not in acute distress, but he has diffuse wheezing. So since the patient had diffuse wheezing, it seems like the asthma is right now uncontrolled, secondary to the upper respiratory tract infection. So the answer was prescribed oral prednisone for 5 days. You want to give 40 to 60 milligrams per day of prednisone for about 5 days. And that has been shown to reduce hospitalizations and also to reduce the severity of the exacerbation within an hour. So that's interesting, because although you know that the receptor for steroids is intranuclear, NFK beta, kappa beta, and I was told in the, like when I studied medicine, that it had to do with the transcription factor, transcription, and it would take 24 to 48 hours to see the effects. Well, yes, we do see in clinical practice that patients improve rather quickly with the steroids, and that is correct. So within an hour, patients will start improving, and of course, the full effect of the improvement will come after several hours. But that was the answer. So when do you give the steroids, additional steroids? When you give systemic steroids for all moderate to severe acute asthma exacerbations, either in urgent care or the emergency room settings, and also in mild exacerbations in the outpatient setting that have been unresponsive to standard inhaler therapy, such as this patient. And that's it for this question. And why wasn't it the intranasal corticosteroid budesonide? Well, although it may reduce the nasal inflammation and upper airway cough syndrome associated with the acute viral rhinosinusitis, it is minimal. It has a minimal impact on the bronchial inflammation and airway obstruction that occur with acute asthma exacerbation. So there you got the answer. And last thing for this question I want to review with you is this real quick. The step-up strategy for asthma treatment in adults. So first you start with, if there's exacerbations less than daily, you just can do the PRN, ICS for Moderol, or you can also do an inhaled corticosteroid with a short-acting beta agonist. But then you go to step 2 here? Well, can see step 2. If you then have most days waking with asthma, now you have to do the inhaled corticosteroid with a long-acting beta agonist and low-dose inhaled corticosteroid, and this is going to be daily. If you still have symptoms, you go to step 4. So daily symptoms or waking with asthma or decreased FEV1, you will increase the dose of the inhaled corticosteroid to a medium to high dose. And if you still have symptoms, now you will probably consider long-acting muscarinic antagonists such as tiotropium, anti-IgE, etc. So that's about it. Let's go on to the next question. Okay, this question is important because it makes you think about different types of diarrhea. Bile acid diarrhea is one that we usually don't think about that much. So I don't think, I don't think about it that much when I'm not in test season, but it's always a good option. Well, when you're rotating in GI, yes, it's something that is very thought about. That's why you always are prescribing patients while you're rotating in GI the bile acid sequestrants, such as cholestyramine. In this specific case, this patient, 22-year-old male with Crohn's disease, had a resection of the 20 centimeters segment of terminal ileum, and now, he is on his therapy without any, yeah, he's compliant or adherent to the therapy and has no findings. The important point of this question is that he has no findings consistent with acute flare-up of his Crohn's disease. So he has normal inflammatory parameters, or his C-reactive protein is normal. His fecal calprotectin is normal. He has been taking his medications, but he is having he's having diarrhea. The diarrhea is just, yeah, no blood in the diarrhea, and he is also having night diarrhea, right? It wakes him during sleep several times. He has bloating, he has flatulence. So the question is asking us what will most likely improve the patient's condition. So the main pearl here is to understand that, well, number one, not all Crohn's patients with diarrhea will have a flare-up. So this patient did not have a flare-up, so you have to think of differentials. And the differential in this case is that patients that have a illness or absence of the ileum, right, can have bile-associated diarrhea. And the reason is because the bile acids will be usually absorbed in the ileum, and if they are not absorbed, the enterohepatic circulation will be interrupted. And if you have that interruption, then you will have diarrhea because the bile acids will not be absorbed and their concentration will be higher into the colon, and it will not permit absorption of water, and it's going to generate diarrhea. It's also going to be associated with the decrease in fat soluble vitamin absorption, and that's what's going to happen. So that's why you have to give bile acid sequestrants so you can treat this condition. So pathogenesis, we already spoke about it. Manifestations, we already mentioned the manifestations, and management. Yeah, we already spoke about all that. So we're just going to see this information here. So dietary lipid digestion and absorption. So the triglycerides you eat in your diet will get to the small bowel, and of course the bile salts that will come from the biliary tract into the basically Wilson or Santorini ducts into that will drop its content into the intestine, will emulsify the triglycerides, and all that will help out with the digestion and generating the chylomicrons, right? The micelles and all that. And if you have no bile salts, you will not have the emulsification, and you'll have all those troubles. So that's it for this one. And let's see what else we have. That's it. So now we're gonna go with the next question. So this next question is important because this is a 20-year-old woman. She is having some heel pain over the last week, and they actually showed us a picture of the heel. So you can see the image here, and that's interesting, right? This is the heel. This would be the area of the Achilles tendon, and this is reddened. So when you take this in context, into the clinical picture, you will understand what this means. This that they're showing you here is going to be enthesitis. So enthesis is going to be the union between tendons, the tendon and the bone, sorry. And the main condition, at least on a test, that will give you enthesitis or inflammation of the where the tendon meets the bone is ankylosing. Well, I think, yeah, ankylosing spondylitis. Not sure if the other seronegative spondyloarthropathies will also produce it. You tell me, but for sure, ankylosing spondylitis. So this patient, basically, that's what she has. Let's see what else there is. Flexion and external rotation of the hip joints elicits intense pain at the gluteal region. That just means that there's a mobility restriction. So the patient has been having chronic hip pain, mobility restriction, the enthesitis. So what's going on? Well, this is ankylosing spondylitis. So what do you have to do? You have to just look for the x-rays to confirm that this is like the bamboo spine, that it looks like a bamboo because there is it rectifying or straightening of the spine. There's no physiological lordosis or, yeah, a little bit of scoliosis, nothing, because it becomes like a bamboo, the way you would see a bamboo. And here you have some information about ankylosing spondylitis. The pain is relieved by exercise. It is worsened with rest. And we already spoke about these findings, at least the motor or the musculoskeletal findings. You can also have some dactylitis or swelling of the fingers and toes, uveitis, so that's another important thing. And it can generate some reduced chest expansion and spinal mobility. So it can generate a restrictive lung pattern, a problem in the pulmonary function tests. And complications are osteoporosis, vertebral fractures, aortic regurgitation. Yes, that's associated with ankylosing spondylitis, Tau-Equina syndrome, laboratories elevated ESR and CRP, the HLA-B27 association with all the seronegative spondyloarthropathies, and imaging, you have X-ray of the sacroiliac joints or MRI of the sacroiliacs. And we got all that information, and we're going on to the next question. So this next question, let's see what we have here. 87-year-old man. He comes into the hospital with respiratory distress. He resides at a nursing home, is bedridden. Let me remember what was going on with this patient real quick. Peripheral haziness, X-ray show left femoral neck fracture. Okay, so this patient had, yeah, left femoral neck fracture. Now he's having shortness of breath, and he's having this skin examination showing purplish discolorations of the chest that do not blanch with pressure. So that gives you the diagnosis, the clinical diagnosis of fat embolism disease, maybe? Well, it's fat embolism. Where? Probably to the lungs, because this patient is having this shortness of breath. So respiratory distress, neurological alteration, and rash. That's like the triad associated with fat embolism syndrome, I believe. Let's just confirm that fat embolism syndrome. Usually any of those lung bones that have a bone marrow in them, when fractured, they're a risk for fat to embolize to the rest of the body. And of course, what are conditions that increase the risk for this condition? That's orthopedic procedures, pancreatitis, and sickle cell disease. Clinical presentation is going to be onset within 24 to 72 hours after the injury. We already spoke about the classic triad. So yeah, there you have it. The petechial rash is associated to that, non-blanching, and prevention or treatment, early immobilization of fractures and operative correction and supportive care. So this patient, you don't anticoagulate. This patient, you want to basically give supportive care. What they're showing us here in this CT scan is ground glass opacities in the bilateral lungs. So here you can see like ground glass opacities all over, and that's part of what you would see on the this syndrome, the embolism, pad embolism syndrome, with some thickening of the interlobular septa. And that's it. Let's go on to the next question. So this next question is, let me remember it. Yeah, this is an interesting one. Okay, let me just remember. Malaise, rash, joint pain in a 29-year-old, previously healthy male. Okay, so this one that usually I have a hard time getting the diagnosis because it's serum-like sickness, right? Serum-like. So acute hepatitis B viral infection may be associated with serum sickness-like syndrome. So fever, symmetric polyarthritis, and urticarial skin lesions without mucosal involvement. So for me, it is difficult to get these questions right, the one that is serum sickness-like syndrome, because I often read these clinical vignettes and I just don't come up with the diagnosis of, oh, this is serum-like illness or serum sickness-like syndrome. But I think that, yeah, after you see this so many times, so often, at least for the test, not so much in real life, you end up understanding it. So what do we have to remember about serum sickness-like syndrome? That it can be associated with hepatitis B, that it'll give you like a triad. So it's going to give you fever, symmetric polyarthritis, urticarial skin lesions. That's a very important one. That does not affect the mucosa. So that's very important. And it says the rash and joint symptoms often resolve within 2 to 3 weeks, followed by development of the icteric phase of hepatitis B infection, and treatment is usually supportive. So let's see what other thing we can learn so we can get this one right on another occasion. Um, let's see what else. Serum sickness-like reaction is due to accumulation of antigen, antibody, or immune complexes leading to vascular and cellular inflammation. The rash is usually pruritic and urticarial with no mucosal involvement. The symmetrical polyarthralgias or arthritis involves primarily small joints and may be associated with morning stiffness resembling that of rheumatoid arthritis. The rash and joint symptoms often resolve within 2 to 3 weeks, followed by development of the icteric phase of hepatitis B infection. Okay, so let's maybe say that cryoglobulinemia is to hepatitis C infection what serum-like sickness syndrome is to hepatitis B. So that would be a good association for you to have in your brain. So hepatitis B, serum-like sickness, hepatitis C, cryoglobulinemia. Their manifestations, yes, they are different, but at least that can help you sort of compartmentalize those two. And that's it for this question. There's maybe some mention here of Epstein-Barr virus. So this is an option. Now we already talked about the clinical pearl. Now let's focus on one of the other options, which was Epstein-Barr. So Epstein-Barr virus mononucleosis usually presents with fever, fatigue, lymphadenopathy, persistent exudative sore throat, and possible splenomegaly. The EBV heterophile test or monospot should be performed more than 4 days after symptom onset to avoid false negative test results. The patient's skin and joint findings make this less likely. Now we're going on to the one of the last questions. So this other patient is a 39-year-old premenopausal woman, and she had a total mastectomy for invasive ductal carcinoma. The cancer is negative, triple negative, so negative estrogen, progestin receptor, and HER2 mutation. So those are the worst ones usually because you don't have much to attack or much to treat. When they are positive for one of these or the three of these, you have targeted therapy modalities. But the point here is that the patient has BRCA1 mutation, and she opted for contralateral mastectomy after she was found to have BRCA1 mutation. So which of the following is the most appropriate next step in management of this patient? So yeah, I got the answer incorrect. I thought you could still do some surveillance here because, of course, BRCA1 mutation is high risk, and it's not only risk for breast cancer but also ovarian cancer, and I think a couple more cancers. So in males also breast, I think prostate, not sure what else, but stomach, no, not sure. But the thing is that elective salpingo-oophorectomy wasn't a crazy idea. It was a good idea actually. You wanted to reduce the risk of this patient having to deal with that, and BRCA1 and 2 mutations make up the majority of the hereditary breast and ovarian cancer syndrome and are found in 5% of breast and 10% of ovarian cancers. Let's see what else we have. So preventative measures include close surveillance, chemoprevention, and risk reduction surgery. Prophylactic mastectomy may be offered to BRCA carriers and reduces the risk of breast cancer by 90 to 95%. So that's great. And those who do not opt for prophylactic mastectomy should have aggressive breast screening with breast self-examination beginning at age 18 and clinical breast examination with annual mammogram and breast MRI beginning at age 25. So pretty intense screening, showing you how bad these mutations can get and or what they can generate, right? Risk reducing salpingo-oophorectomy should be offered to patients aged 30, more than 35 or 40 who have completed their childbearing plans. So that's about it for this one. Let's just wrap it up talking about some factors that increase risk for hereditary breast ovarian cancer syndrome are personal history, of course, of ovarian cancer, breast cancer before age 40, a family history of breast cancer at young age, bilateral breast cancer, breast and ovarian cancer, or male breast cancer, and the triple negative breast cancer and the Ashkenazi Jewish ancestry. And so that was question 11. Now we're going to question 12 out of 14. So only now we're going to go quicker to wrap this up because we have to go do more things today. So this patient has psoriasis. It is just limited to what you see in the picture. So it's just limited to those knees. And the patient has not had any prior symptoms, does not have any arthritis. It just has some mild itching that worsens in winter and no other symptoms. So the question is, how do we treat this? So yes, it looks like plaque psoriasis and the extensor surfaces. How do you treat it? Well, if it's mild, you will do topical corticosteroids and calcipotriene. And that's it. That's the treatment for the psoriasis, of course, for mild. So main point is mild to moderate plaque psoriasis should be initially treated with topical corticosteroids and emollients. Combination therapy with topical steroids and vitamin D is more effective than either therapy alone. For facial or intertriginous involvement, topical tacrolimus or pimecrolimus may be used as corticosteroid-sparing agents. Phototherapy and systemic therapy, such as methotrexate or biologics, should be used for moderate to severe disease in consultation with a dermatologist. And that's it. Let's go on to the next question, okay? Next question is question number 13. And here, okay, by this question, I just reviewed it a while ago, but I was already falling asleep for a moment. So let's see what we remember. This patient here is a 24-year-old woman with some lumps on her neck, night sweat, weight loss. Okay, those are constitutional symptoms, and it sounds like lymphoma. And it was a non-Hodgkin, I think. Was it Hodgkin or let's see. I think it was Hodgkin lymphoma. Yeah, this patient has Hodgkin's lymphoma. But I got this question incorrect because I'm like, okay, this is Hodgkin's lymphoma. Which of the following is the most appropriate next step in management? So I'm like, okay, CD15, CD30. I thought, was that Hodgkin's? So I thought it was associated with my vague recall of step one information. And I'm like, okay, yes, this responds well to chemo. Let's go with the chemo immediately. So I put this patient on chemo right off the bat. But that was incorrect because the main caveat here is that before you put this patient on chemo, pay attention if they want to become pregnant or not, because that chemo can be toxic and avoid the possibilities for this female to be pregnant in the future. So this patient had to first have a fertility specialist referral before starting the chemotherapy. And the educational objective says increased cure rates and long-term survival for patients make quality of life issues such as fertility preservation important. Referral to reproductive endocrinologists must be made as early as possible after diagnosis to avoid treatment delays. So if it was something that was basically, yes, killing this patient right there on the spot, a horrible derangements and the whole thing, probably you don't have time for a fertility specialist to see the patient, and you just would have to go ahead and treat, but not in this patient, right? Let's see what other patients, for example, would actually, let's see, patients with advanced disease, especially leukemia or lymphoma, may not be able to discuss fertility preservation due to need of immediate therapy. Yes, but this patient could potentially see a specialist and potentially get embryo or oocyte cryopreservation and then start the chemotherapy, etc. So last question is a patient that basically has shortness of breath. It has an angle of scoliosis of 67 degrees. I don't remember what was the normal, but that sounds off. That sounds pretty bad. And remember, scoliosis is to the side, kyphosis is to the front. But the patient has scoliosis and kyphosis above T10. Which of the following is the main mechanism of respiratory compensation in this patient? So this patient is having fatigue, which has been and shortness of breath progressively over the last year. So this is going to be restrictive lung disease, and it's extrinsic. It's actually the anatomical abnormality. It's not the lung parenchyma that is bad. It's the position. It's the mechanics that are bad. So of course, how can you compensate? Well, you will have, of course, a lower tidal volume because there's restriction, but you'll have to breathe faster. So that was why that is the answer. Low tidal volume with high respiratory rate breathing. And the main point here is that angles of scoliosis above 65 degrees and kyphosis above the level of T10 are the greatest risk for impairment of the respiratory mechanics. And that's it with this one. See you in the next one.